He's a known master cerebrovascular surgeon from China, and his experience in revascularization and in all kind of cerebrovascular pathologies, either brain and spinal cord, is unmatched. He's a professor of neurosurgery at the Washan Hospital Fudan University in Shanghai, an honorary vice chair of the Chuha International Neurosurgical Academy. His practice focuses, again, on cerebral and spinal vascular diseases, both interventional and open. Specifically his personal experience in bypass and in revascularization in general is more than 5,000 cases, performing around more than 700 cases a year. Correct me, Dr. Su, if I'm wrong, but those are the numbers. So thanks for being here with us today, and we're going to speak about revascularization in Moyamoya disease. Please, Dr. Su, you can share your screen.
Okay, thank you. Thank you, Costa.
Thank you.
So I'm very happy to be invited by the Seattle Science Foundation to present my experience in the revascularization for Moyamoya disease. So I come from Huashan Hospital. So our neurosurgical department may be the Chinese biggest one. We totally have 4 campuses. Last year, although there's some COVID-19, but we still have 13 operations and 4,800 cases of gamma knife and the cyberknife case. So totally we have 800 beds, 40 operating rooms, 1 central laboratory, and we are the WFNS and the ACNS training center. So after the COVID-19, you are welcome to visit us in the near future. So this is my personal experience in bypass. My personal record is 5 minutes, 40 seconds to finish a stoma. 13 cases in 1 day, 41 cases in 1 week. Now I almost have 9,000 bypass totally in 112 hospitals in China and India. So we just published this surgical techniques in Moyamoya vasculopathy. I write the 1 chapter for the late Moyamoya disease. So this is we do the live case in India with Professor Yoko Kato. And in 2 years ago, we visit Mayo Clinic, and we have a cerebral bypass and advanced endovascular course with Professor Lanzino. So this is a typical Moyamoya according to the Suzuki stages. This is stage 1. We can see the stenosis of the distal part of ICA and the proximal part of ACA and the MCA. This is stage 2. We can see the Moyamoya vessels come from the M1 and the A1. This is stage 3. We can see a lot of Moyamoya vessels. Stage 4, actually stage 4 comparing stage 3, the Moyamoya vessels decreased. This is stage 5. We can see some spontaneous stoma come from the ECA branch. In this case, we can see the stoma come from middle meningeal artery. This is stage 6. We can see the ICA totally occluded, and only some Moyamoya vessels come from the PCA to collateral, the whole brain. And this is a Moyamoya syndromes. Like this patient, we can see the MCA occluded. We also have some special Moyamoya syndromes. Like this patient, we not only have the Moyamoya, but also have the AVM. This is another case of Moyamoya combined with the AVM. So I resect the AVM and then do the direct bypass. So for the revascularization of the Moyamoya, actually we use three branches of the ECA. They are STA or postauricular artery or occipital artery of the scalp. And the temporal muscle, we have anterior deep temporal artery and the posterior deep temporal artery. In the dural, the main feeder is the middle meningeal artery. So in my personal series, only 14 cases, the surgery was not necessary. You can see like this patient, actually the middle meningeal artery formed a lot of spontaneous stoma with the cortex. So this patient already have relieved by the ECA branches. And this patient is so lucky that that you can see the middle meningeal artery was so big, and the blood flow come to M2 and redistribute the blood flow to the whole MCA territory. But for most of the patients, even the stage 5 or 6 stages, the middle meningeal artery already formed the spontaneous stoma, but they are not enough. So they're still suffered from ischemia. So we need to do the surgery. But we should keep the intact of the middle meningeal artery. Middle meningeal artery also can be originated from ICA branches, like this patient. You can see the ECA angle. You couldn't find the middle meningeal artery, but in the ICA angle, you can see the MMA come from the ophthalmic artery. So we normally use the combined approach, STA or postauricular artery or occipital artery to MCA or ACA or PCA bypass combined with the EDMS, encephalodural myosynergesis. For pediatric patient younger than 7 years old, normally wide EDMS is enough. This is a skin incision, the bone flap, the dural, and the targeted bypass. Every layer was individualized, designed. So this is a skin incisions. So I don't use head clamp to protect the collateral, contralateral STA. Sometimes we also treated the invalid bilateral EDAS from other hospitals. But in some cases, we should give up direct bypass in this condition. Like in the left picture, you couldn't find any recipient artery in the whole wide surgical field. So the recipient arteries is too small. In the right side, you can see there's some MCA branch was occluded, like this one totally occluded. And in this side, you can see the very tiny reflux from small branches. So this technically for this branch, it's feasible to do the direct bypass, but the network of the MCA was too poor. So if we do the direct bypass, the distribution of the blood flow is a problem. So it can cause the bleeding. This is the STA, postauricular artery, under the occipital artery. You can see normally in male patients, the STA was quite thick. And in female patients, the diameter of the STA or postauricular artery was smaller. So this is a dissection of the STA from inner side of the scalp. Use a small power monopolo. You can dissect the STA very quickly in minutes. After harvest the STA, I close the incision of the superficial temporal fissure from inner side. Sometimes even two-layer suturation, occluding the galley under the superficial temporal fissure. If the circles of the STA was too wide, I will fix it with a dural strip like this. So after this treatment, the delayed scalp healing or infection never happened. So keep the integrity of STA, deep temporal artery, and the middle meningeal artery network is very important. So every layer you can see the vessel network was kept intact. In the whole craniotomy, we control the bleeding very strictly because this kind of patient already suffered ischemia. So we have to control the bleeding volume less than 20 milliliter. For the late stage Moyamoya disease, like stage 5 or 6, normally they have some spontaneous stoma come from the middle meningeal artery. So we have to keep it intact. So the best way to protect the middle meningeal artery is keeping the integrity of MMV under the covered bone complex, like this bridge, bone bridge. So I designed this two bone window. This is some special cases already have some spontaneous stoma. So sometimes we created the single bone flap, combined multiple hole, and sometimes the double frontal bone flap in the normally for the invalid bilateral EDAS case. The dural was also individualized cut along the main branch under the main trunk of the middle meningeal artery. In this picture, we can see the spontaneous stoma come from middle meningeal artery to the cortex. Under the microscope, you can see the middle meningeal vein was always like sinus. So the middle MMA was come in MMV. So we have to stop the bleeding from MMV at the same time to keep the intact of the MMA. So I created this way. Use a strip of gel foam, compress the MMV, and so I created this Chinese spring roll to keep the integrity of the MMA at the same time to hemostasis of the MMV. The stoma is located in ischemic area, but not the infected ones. So I always use the most simplified anastomosing, which means use 1 or 2 or 3 curved microtemporal clip to clip the recipient artery. So don't need to sacrifice any branch of the recipient artery. I never use rubber mat or silicone rubber tube to assist the anastomosing. I always use interrupted suturing. Square knot is enough. Sometimes I also use the loop technique. Use 2 curved microtemporal clip, then cut the oval shape anastomose. First needle located in the toe, then the here, then one side, 4 loops, makes 5 knots. The other side, so totally 12 knots. This is after the bypass. You can see the intraoperative ICG. So why I always use interrupted suturing? Because the stoma can be enlarged. If you use continuous suturing, actually it can limit the enlargement of the stoma. So the targeted bypass means sometimes we use a single bypass. If the MCA network is quite integrated and quite good, we can use double or triple bypass like these patients. Actually, in the Moyamoya patients, we have 2 kind of pressure gradient of the MCA. So this is the first type, still keeps the physiological direction. So the P proximal is larger than P distal. So the blood flow still comes from M1, then to M4. But there's some special cases. Actually, this is second pressure gradient of MCA. You can see the M2 was the latest phase of the angio. So this is a reversed physiological direction. For this patient, the P proximal is less than P distal. There's a lot of intermediate states. The direction of the flow within cortex blood vessel is complex. So we should select the good recipient location. So after the delta P is positive, you can see the red T in the flow 800. This is a single bypass. You can see this is the red T sign, and this is a double bypass, 2 red T. So the red T means bi-direction fast blood flow, and it means the big difference of delta P. So this kind of bypass is sustainable. So if the you have see the red T of the one short arm, like this patient, so this delta P is barely positive. So you can see it's although it's patent intraoperatively, but in 2 weeks, in 1 week, the STA was almost occluded. So this is a case borrowed from Zhang Jianjian from Wuhan. So after the direct bypass, actually in every case, the new watershed was formed because there's some balance point between the ICA and the ECA blood flow. So this kind of watershed is a 3-dimension curved surface. And the pressure equilibrium of ECIC is a decisive factors. So we can see the good MCA network in the early stage of Moyamoya disease. So in the angiogram, you can see the MCA branches still quite clear. So this means a good MCA network. But in the late stage of the Moyamoya, you couldn't see any MCA networks. So this is a poor MCA network, can bear small amount of blood flow from donor artery, and it's dangerous for bleeding. So in the good MCA network, you can see After the double bypass, the blood flow reflux to M2 and then redistribute the blood flow along the MCA network very quickly. So the MCA network is quite important, is a key rule to determine the blood flow volume in bypass. So we use a NOVA intraoperative NOVA system to measure the blood flow. Actually, intraoperatively, normally the blood volume from the for the Moyamoya vessels almost only 20 to 40 millimeter per minute. But after 7 days, you can see this single bypass increased to 77 millimeter per minute. For the double bypass, after 7 days, it can increase to more than 100 millimeter per minute. So the time is also very important. For the good MCA network, like this patient, you can see the right side, the MCA network is quite integrated. So this STA increased in size and paired a lot of blood volume. So the right STA, the blood volume is 140 millimeter per minute. But on the left side, you can see the MCA was very poor, and the STA only carry on 91 millimeter per minute, almost 50 millimeter per minute less than the right side. So on the right side, you can see the STA diameter increased to 3.3 millimeter, feeding the big MCA territory. But on the other side, the same patient with poor MCA network, the STA bypass diameter is only 0.9 millimeter, feeding limited superficial territory, only one branch of the M4. So besides the parameters in Poiseuille's law, the condition of the recipient MCA network is also a key rule to determine the blood flow volume in bypass. This is a long-term blood flow change in different arteries. You can see the blood volume always increase in the branches of ECAs from STA, middle meningeal artery, and the deep temporal artery. For the ICA, it's always decreased, and even the blood flow decreased in the basilar trunk artery. You can see the posterior circulation. The blood flow was decreased after the left side revascularization. So after a successful revascularization, you can see the upper pictures. This is a young man. You can see the whole brain was revascularized by the ECA branches, and the ICA was totally occluded. In the lower, another case, you can see the ICA only need to feed the basal ganglia, and almost all the cortex was fed by the ECA branches. For this patient, you can see the STA increased a lot, and not only fed the left hemisphere, but also the right frontal lobe. So for the MCA network with a good integrity, normally in the early stage of Moyamoya, Suzuki 1 to 3 stage, some even in some stage 4 or 5 patient, and most of the Moyamoya syndromes, actually the minimum invasive direct bypass is possible. In this kind of patients, the main feeder is STA after operation. So the many patients have a physiological resistance to large incision and the large bone flap, leading to the continuous disease progression and even loss of direct bypass opportunity in the future. You can see in patients with good MCA network integrity, the main feeder is STA after operation. The MMA and the DTA, although have some still spontaneous stomas, but contributed little. So this is I tried. Now I already tried in around 12 cases. Take this minimal invasive approach. It's a very small incision, small bone window, and keeping the hair. But first, we should choose the right recipient artery with a large positive delta P to make sure the bypass patent. Before this operation, we did the angiogram by ourselves. So the first type, donor artery and the recipient artery are very close at a certain position. Like this patient, you can see the donor and the recipient artery almost at the same position in this way. It's only across the bone window. And we measure the distance between donor and the recipient artery. AP view only 9.81 millimeter. The lateral view only 2.3 millimeter. So we calculating the length of the skin incision and the diameter of the bone flap. Actually, the diameter of the bone flap only need 2 centimeter. The length of the incision is only need 4 centimeter. So this is selecting the segment of STA between the two bifurcations, the landmarks in this in the surgery. Then selecting the segment of the recipient artery. The length we only need to expose is 14 millimeter. So this is a surgical plan, and this is a real surgical view. You can see the real surgical view. It's same as a surgical plan. This is a stage 2 Moyamoya. You can see after the incision, we dissect the STA from also from the underside of the scalp. You can see this is a bone window. Then cut the STA. This is a recipient artery. You can see it's in the circles, but it's enough to perform the anastomose. Temporal occluded the recipient artery. then perform the anastomose. So this is a picture after the bypass. You can see the bone window is very small. It's only 2 centimeter. And the post-operation CTA, you can see the left MCA was supplied by STA. So there's no blood flow from M1. So the second type, there's some distance between the donor and the recipient artery. You can see this is the position of, we selected the recipient artery, and this is the donor artery. So we have to shift the STA to the location of the recipient artery. So we use this curved incision. This is the right side. You can see the curved incision. This is a post-operation DSA. You can see the bone flap is very small, and the STA MCA bypass was very patent. This is a change of the blood flow in MCA network before and after bypass. Before the blood bypass, the MCA will still come from the M2 blood flow still come from the Moyamoya vessels. But after the bypass, you can see the all the MCA network, the blood flow come from the bypass. So this is a video for this case. Still dissect the STA from the scalp. Then cut the distal part of the STA. This is the methylene blue, the heparin saline. Then expose the recipient artery. You can see the blood, the pressure of the artery was quite low, so the color is very pale. Then cut a oval shape stoma. I always use the oval shape stoma because according to the Bernoulli's principle, this stoma, oval shaped stoma, the local resistance is the lowest. Comparing the fish mouth stoma. The first stage at the toe, then the here. This is a 10-0 purling suture. So then the 3 o'clock. Then 9 o'clock. So these are unedited video. You can calculate the time. So in 8 minutes, the stoma was finished. Then remove the distal temporal clip. Then the proximal one. And the temporal clip for STA. Okay, actually, we are still learning every day. You can see, although we, in this picture, actually, you can see the change after the blood flow, after the bypass was so dramatically. You can see in the left side, this is a big vein. You can see the turbulence in the vein, not only in this side, but also in another side. Then between this segment, actually the delta P between these two ends is very small, and the blood flow is very small in this segment of the vein. And this is a change of the STA under the recipient artery. So the circulation time from artery to vein is shortened dramatically. So it's a very big change comparing especially the vein pressure. So this vein pressure's change can cause some infarction by the of the neighbor cortex. This is a main cause, I think, for the neighbor cortex ischemic condition after the direct bypass. So we are still learning every day. Thank you.
Thank you very much, Dr. Bing Su. That the talk was just fantastic. We're here with the fellows.
Thank you.
That's one of the best talks we had. So we will start with one question from. We have many questions, but the first one is going to be from our director of neurosurgery, Dr. Cameron McDougall. He wants to ask you. He says that you have nicely explained the importance of the quality of the recipient network for the viability of the bypass graft. He asks what do you do? What measures you take in your procedures to try to compensate for the cases where the recipient network is poor?
Actually, you can in the angiogram, you know, because my team is not only a open surgery team, but also we did a lot of endovascular treatments. So the angiogram was always performed by ourselves. So for the Moyamoya angio, we have some special changes for comparing to the normal angio. Like we will inject the contrast in a quite a long time and in a low dose. So then we can find some position of the late phase of the artery. So actually we can calculate the delta T of the comparing to the STA under the recipient artery. Actually, this kind of delta T also presented the delta P, because the late phase of the recipient artery means the lower pressure in it.
What are those times? So, I mean, in order to replicate that, what are those times that you use for an injection in Moyamoya, the contrast?
For this kind of, normally we have inject in 4 seconds, maybe 4 or 5 seconds. It depends.
Okay, is it hand injection or?
Oh, we use a machine. You can set the machine. Yeah.
Okay, so another question here is the chances. What are the chances of getting skin flap necrosis when you use bilateral STAs?
Normally no problem, because most of the cases we use we only use the parietal branch of the STA. So the frontal branch normally is intact. So the blood flow for the flap is enough.
Okay. then do you open the fissure to find some larger recipient artery when you have no good M force, for example? Is there any role for getting deeper and looking for a bigger recipient?
Yes, most of the cases we use a big craniotomy. Not only the direct bypass, but also the EDMS, encephalodural minor synergiosis. So normally the bone flap at least like this big. So you can always find the recipient artery.
Okay.
The biggest one, yeah.
Okay. How do you choose to do combined? Is another question. I mean, you always use combined bypass in Moya?
Not every time, because I actually in the late I always use some combined approach, but in the early stage of the Moyamoya, I presented several cases. Only use a very small craniotomy.
Okay.
To do the direct bypass. Yeah.
Okay. Another question is, how do you approach Moyamoya with associated aneurysms? Do you treat the aneurysms first? How do you?
This kind of aneurysm, actually, there's two types of the aneurysms. One type is in the circus Willis circus. Actually, this kind of aneurysm, we can mostly we can embolize it. Sometimes we can open it and direct clip it. But for more commonly, actually, the aneurysm was a peripheral pseudoaneurysm. For this kind of peripheral pseudoaneurysm, normally you can wait 1 or 2 months. Then after you redo the angiogram, it can disappear. So this kind of pseudoaneurysm, small pseudoaneurysm, you didn't need to treat it directly.
Okay. Next question is, how long do you wait between the last episode of TIA or stroke in a Moyamoya patient and the surgical procedure? There is any wait?
It depends on the MRI. If the MRI, there's no infarctions, actually TI is not a big issue. If there's some infarction, we will wait for about 6 weeks.
Okay. Our next question is about how do you manage the antiplatelets pre and post operative?
It depends. If the patient have TIA, we will use antiplatelet drugs. So it's not a contradiction for surgery. But normally we didn't use it pre and after the surgery, because Chinese people or East Asia people, I think it's more sensitive to this kind of drugs like aspirin. Yeah, normally we only take 1/3 of the dose of white people. Yeah.
One question from us is, how do you identify the positioning in the craniotomy of the transdural collaterals beforehand, so you don't damage them? Do you use navigation?
Actually,
or
yeah. Actually, you can measure the middle meningeal artery with the coronal circles of the bone flap. Actually, sometimes you can even find the big MMA through the bone window, because it's always it's very thin thin bone cover the middle meningeal artery. But normally you can see, normally it's located at the terium position. So this kind of coronal circles is a landmark for find the middle meningeal artery.
Okay. You also spoke about the NOVA technology. Could you please explain how it works? I mean, physically.
It's a intraoperative MRI. This is created by Professor Fadi Shaber in the Illinois University. Yeah.
Okay, so with the NOVA, you can predict.
You can measure the blood volume of the vessels.
So you can beforehand predict the failure of the M4 as a recipient, right?
That's no. Only measure it after the bypass.
Okay.
And you can check the change of the blood volume in the bypass in several days or even months after the operation.
Do you use flow ICG in the cases also? In every case?
Yes.
Okay.
Almost every case.
Almost every case. And another question is, what is your advice for trainees regarding, I mean, for the learning curve of bypass to go faster?
Maybe you should come to us and visit. Every day we have so many cases. So maybe you can observe maybe 100 in maybe 2 months. So that would be let you unforgettable. You will feed up very soon.
And regarding the lab exercises, you would advocate lab, I mean the animal work or dry models?
Yeah, animal, rats. Rat is the best. Yeah.
Okay. Any other questions?
Yeah. Occipital artery.
I'm here with one of my colleagues, Muhammad Bassam.
Do you use for if you have some cases? We've seen some cases with mainly posterior MCA territories, ischemia or PCA. Do you use occipital artery for those, or?
Yes. I presented some case, but because the time limitation, I didn't explain on the pictures.
Okay.
So I not only use frontal lobe or parietal lobe of STA, but also some occipital artery. Sometimes, if the patient don't have the parietal branch of STA, normally they have post-auricular artery. You can also use it. So the incision is according to the these 3 arteries.
Dr. Bingsu, do you, in case of Moya, do you perform bilateral revascularization in the same setting, and you wait between them, you space them out?
Normally, we will retreat do the contralateral surgery after 4 to 6 months.
4 to 6 months.
Yeah.
Do you have any tips to harvest the occipital artery?
Actually, for occipital artery, it's for this segment, it's quite easy, not very difficult, because if it's deep in the muscles, it's quite difficult to find. But in this segment, it's quite easy. Yeah.
Okay, there is one question here. If you had any cases in which the intraoperative ICG was patent, but in post-op was occluded?
Yeah, it's there's some competition between the different branches of the ECA. So sometimes the STA can be occluded after the spontaneous stoma come from middle meningeal artery and the deep temporal artery. So if this kind of spontaneous stoma can deliver the blood flow more efficiently than the STA, actually the STA can shrink, even occluded. Yeah.
Okay. One of the attendees asks, how can you avoid the postoperative low perfusion around the anastomosis site?
a low perfusion.
Yeah. Like,
actually, you couldn't avoid. You know, actually, I just mentioned that I don't use the hypoperfusion syndrome because the neurological deficit, the temporal neurological deficit, there's two causes of this kind of TND. So one is real hypoperfusion because of the blood volume from the donor artery was quite high. But actually, we analyzed the SPECT for around 80 patients. Actually, half of this kind of patients, they suffered hypoperfusion. So I explained that the pressure in the vein elevated because the circulation time from the donor artery to the main train vein, it's quite shortened, and maybe the service veins, the pressure is quite higher. So actually, the perfusion pressure for the nasal cortex may be decreased because you didn't give them additional pressure from the artery side.
okay. So there are some questions in general about revascularization. I will try to address two of them.
Sorry, but for this kind of TND, normally in 2 weeks they can be relieved and totally recovered. So don't worry about it.
Okay, in your mind, what are the most important postoperative considerations for these patients?
For what kind of patient?
In general, in revascularization for Moyamoya, either direct or indirect. What are the most important factors that you want to have under control in the post-operative period?
If the patient suffered from some TND, you can you should use a SPECT or some CTP to measure if it's a real hyperperfusion syndrome. You can decrease the blood pressure, maybe 10%. And if it's a hypoperfusion, you can actually dilute the blood and maybe make the blood pressure a little bit higher than the baseline. Yeah.
And last question is, how do you address infarcts arising from watershed zones coming from the main ACA and the donor
yeah,
side?
this is a actually you couldn't avoid any infarction. Sometimes normally it happened in the frontal lobe. I already explained maybe the reason of the pressure of the vein increased, maybe is a reason. So maybe diluted the blood volume is we always use if the patient have some infarction, normally we will dilute the blood immediately and increase the blood volume, increase the blood pressure a little bit. Yeah.
Okay. There is another question here. What is the ideal time for post-operative angiogram? And if you
it depends. If you want to measure the blood volume, we use post-operative MR NOVA system. You can measure the blood volume. If you want to check the patency of the bypass, actually you don't need to do the angio, angio immediately. You can use ultrasound. It's very convenient and Actually, it also can be measured the blood flow.
Okay. And in the preoperative period, do you use CT perfusion or MR perfusion? What is your choice?
Yes.
Which of them?
Normally we use MR ASL sequence to measure the ischemic condition.
In case of recurrence.
Yeah.
In case of patients who failed the graft occlusion and they come with recurrent symptoms, how do you approach these problems? Do you wait for indirect bypasses to form, or do you opt to do a new bypass?
Actually, in my personal series, there's no this kind of patients. It's
okay.
Always patent, yeah. So
okay.
only the late occlusion happened. I already explained that because of the competition between different branches of the ECA.
Okay. Okay, Dr. Su, that was fantastic. Thank you very much for your time. We really appreciate it. It's super useful for us, for the fellows and everybody. So thank you very much.
Thanks a lot.
Thanks a lot for your time, and hope to maybe invite you again. Bye-bye.
Thanks.
Bye-bye. Thank you.
Thanks.